My name's Sam, like Rose Oliver. I'm Policy and Public Affairs Manager at Locality.
So my name is Balinda Desange and I'm a Clinical Engagement Access and Inclusion Coordinator for the Leeds Perinatal Mental Health Service.
Jeremy Simmons, I'm Policy and Programme Manager at FaithAction.
I'm Peter Kik. I'm the Graduate Policy and Engagement Officer at FaithAction.
So Locality is the membership network across England for community organisations. So we represent and support about 2,000 organisations working locally in their neighbourhoods, supporting local communities of all shapes and sizes, really. So we work in a number of ways to make sure that they can be as strong and successful as possible.
FaithAction exists to empower faith-based social action, but also to take the voices and experiences of those organisations and people of faith and bring that into the policy-making space. And really our focus has been on exploring what role can faith communities play and faith leaders play in improving equity of services and reducing inequalities. We've spent a couple of years really engaging with different faith communities, and we spent the last year developing a toolkit aimed at faith leaders themselves. So really talking to the faith sector about what practically they can do to get involved locally and to work with local maternity systems and really make a difference to those inequalities.
I help raise awareness of perinatal mental health difficulties within diverse communities within Leeds. Sometimes it can be really difficult for people from particular groups and particular communities to really get the help when they need it. So that is something as part of my role, as part of the engagement side that I help to do. And the other thing as part of my role is helping to support the frontline and leadership team within my service to help them to provide a culturally responsive service. So basically looking at how we can be, as a service, be more inclusive and how we can work together to improve maternal mental health outcomes.
So I think it's the only way really to create truly inclusive and culturally competent services that really effectively meet the needs of the communities they aim to serve. So where communities, and whether that's either communities of place or of interest or identity, are marginalised and exposed to more acute health inequalities as a result, that services designed to support them will only really be effective if they are designed in a way that is as accessible and acceptable and available to those communities as possible. And the only way really for that to be ensured is for the insight of those communities into what works to be placed at the heart of that service design.
You can't design effective and inclusive services without including the people who will benefit from and experience those services in the process. You don't know what you don't know, and you can't assume what people's experiences may be. So we have to involve people, we have to talk to them, we have to listen to their experiences and the way that they view the world.
People with a lived experience are the absolute experts in accessing healthcare that we provide. They're the people who actually are able to help us as a service identify what the challenges are, what the barriers are, where the improvements are really needed, and especially to help reach out to other people within their own communities. For example, something which is often misinterpreted, something which is such a taboo subject when we talk about mental health, and having people with that real life lived experience helps us to connect with our local community, with our places of worship, for example, with our faith leaders, and help us on a grassroots level to really make those tangible changes that we really need to make in order to make our service inclusive.
We live in an incredibly diverse society, and that includes a diversity of faith beliefs about health and care, about how people might want to experience services. We've discovered this last year that often that faith lens, the way that people see the world from the perspective of their faith, isn't considered necessarily in thinking about health and care or in thinking about maternity services. And that can include such a range of things, whether it's, how might my faith affect my decisions about screening, for example, or vaccination? How might it affect my attitudes to breastfeeding, for example, or the involvement of partners within the pregnancy journey. These are all things that came out of our engagement.
What we've noticed is, from looking at our data, that has increased in terms of the communities that we have been reaching out to. So when previously I first started 4 years ago, we saw a lack of people coming in from particular communities such as the Sikh community and the Muslim community. And now what we're seeing is an increase actually. So we're now actually meeting the regional data, which is in terms of requirements. So that's really, really good. Also, in terms of, working in partnership with our local maternity services as well has been key in terms of making improvements, such as we've created, helped the maternity services to create a perinatal leaflet, which has been designed and co-designed and co-produced with our service users and volunteers that we recruit from diverse communities, for example.
There are some examples of good work, I think, in terms of partnership work between faith and services locally. We know, for example, we did some work in East London, and within that local maternity neonatal system, there was engagement of faith leaders in the development of their equity and equality action plans, which is really encouraging.
Well, there are definitely positive impacts on the health inequalities of the communities served. So peer-led health promotion, as we talk about it, is a really good example of this. That's kind of based around the idea that the messenger is as important as the message. So one of our members, CB Plus, who work in North London, run a programme commissioned by Brent Council called the Health Educators Programme. And that's very much about using local people from local communities, people who speak community languages, who are trusted and have access to community spaces, and that might be includes kind of faith-based places as well. Being used to share and to engage local people in their communities in health messaging in a way that is understandable, that's accessible, that is culturally competent.
Building trust with our local communities has been key as well. So connecting with our local places of worship, building trust within the community on the ground has been key. We're able to create mental health workshops that we're doing as well and deliver mental health workshops. So what we're doing is we're really empowering our local community with knowledge and skills to help them make informed choices when it comes to accessing support for perinatal mental health difficulties. So people are aware of how to access it, what are the signs and symptoms to look out for.
There is a lot more that can be done in terms of joining the dots between faith communities and maternity services. That's something that we've really learned. So we're moving towards this year launching a campaign that we hope will be rolled out among faith communities. And we really want to be making the case to faith leaders, but also to LMNSs and other communities, other voluntary groups, about the need for partnership work in this area and that opportunity to kind of make commitments to engage in practical work.
Use the toolkit and the campaign to empower faith leaders and faith communities to navigate these inequalities and tackling these inequalities where they may not have the direct medical knowledge, but they're able to engage and participate in projects and initiatives that can help almost mitigate some of these outcomes that occurs in these inequalities and in their communities.
It can be hard to know where to start in thinking about engaging with the faith sector and involving the faith sector. There are lots of different kinds of faith organisations, from places of worship, whether that's mosques or churches or temples, gurdwaras, or whether it's charities and faith-based organisations or individual faith leaders. Most local authority areas will have a local faith forum, and that will have a named contact that you can reach out to if you're interested in kind of making that first contact with the faith sector.
ICSs should really support their VCSE alliances, and local authorities should support their local VCSE sector to feed in real-time information about their communities to inform commissioning decisions. Engagement with communities should happen early and often in the commissioning process to ensure that services are designed to be culturally competent from the start and then delivered as such. The ICBs should ring-fence part of the health inequalities and unmet needs adjustment in their core allocations to provide remuneration really for community organisations to play a role in the service design, understanding that otherwise capacity and resources are very stretched and they need support to be able to engage in that really valuable way. But also the VCSE sector itself must strive to be more representative of all the communities that they serve and ensure that the voices of those most marginalised are heard within the health system.
I think having representation within organisations and services of people who are representing the local community really, really matters. Our local places of worship, our local communities are asking to see people who look like them, who talk like them, and who reflect, you know, their community and their background. And that really, really matters. What's made a difference is using community languages as well. So I'm able to speak in Punjabi, which has really been key to having conversations with the local community. I'm able to have that conversation on a you know, same ground as them really, and which is key in helping to raise awareness. But also what we're doing is, you know, we're taking people with lived experiences along our journey with us, and we're working together. We're listening to what our patients are saying. We're recruiting volunteers who are people with lived experiences, who have accessed our service, and they're from diverse communities, who are able to support us with reaching out to the local community, because what they're able to do is share their experience of getting the help and share their experience of why this matters and the importance of breaking down the taboo and the importance of normalising conversations around mental health within our communities to support our family members, to support our sisters, to support our mothers, our, you know, aunties out there who are desperately needing that support really.
Coming out the pandemic, there were a lot of bridges built with communities out of that necessity of the emergency that we were in. And really our recommendation to a lot of systems at this point is, you know, explore where are those connections already. You know, where did you run vaccination campaigns, COVID vaccination campaigns? Where has there been work around winter pressures? What faith leaders are in touch with the system, and can those connections be leveraged to actually do some work around maternity?
Being consistent. So once you've, you know, built that relationship out there with the places of worship, for example, consistently meet up with them on a regular basis. I've been doing this work for the past, in terms of going out and doing that community engagement work for the past 3 years now, and I've consistently gone along to all the Sikh Gurdwaras in Leeds, for example, all the mosques in Leeds, you know, whether that be a weekly basis, whether that be, you know, every fortnight. I've made that conscious effort of, this is not a 9 till 5 job. It's a matter of fitting in with our community. Our community actually needs us, and they are very welcoming the support that we provide. So it's making sure that we are adaptable and we are flexible. We can meet our community needs and work around them.
Of course, if you do want to get in touch with us at FaithAction, we can always advise and help and see if there are opportunities to link people up locally with faith communities.